ACLS Test 2026 AHA Pretest 40 Questions Answers Part 2. Question 1. What is the recommended dose for a second bolus of amiodarone in refractory VF/private? Option A, 300 mg. Option B, 150 mg. Option C, 100 mg. Option D, 50 mg. The correct answer is option B, 150 mg. After an initial 300 mg dose of amiodarone, a second dose of 150 mg 4/IO bolus may be administered if the shock refractory rhythm persists. Question 2. A patient in cardiac arrest has a PEC O2 of 8 mmHg after 10 minutes of high-quality CPR. What does this suggest? Option A. The patient is about to achieve ROSC. Option B. CPR quality needs to be improved or the prognosis is poor. Option C. The patient is hyperventilating. Option D. The endotracheal tube is in the correct position. The correct answer is option B. CPR quality needs to be improved or the prognosis is poor. A PEC O2 less than 10 mmHg indicates low cardiac output and poor CPR quality. If PEC O2 remains below 10 mmHg after 20 minutes of high-quality CPR, it is often a predictor of failed resuscitation. Question 3. Which drug is used specifically for stable, regular wide complex tachycardia, if not Torsades? Option A, atropine. Option B, procainamide. Option C, epinephrine. Option D, vasopressin. The correct answer is option B, procainamide. Procainamide, 20 to 50 mg/min, is an option for stable wide complex tachycardia. Avoid in patients with prolonged QT or CHF. Question 4. What is the total maximum dose of lidocaine in cardiac arrest? Option A, 1 mg per kilogram. Option B, 3 mg per kilogram. Option C, 5 mg per kilogram. Option D, 10 mg per kilogram. The correct answer is option B, 3 mg per kilogram. The maximum dose of lidocaine is 3 mg per kilogram. The initial dose is 1 to 1.5 mg/kg, followed by 0.5 to 0.75 mg/kg every 5 to 10 minutes. Question 5. When using transcutaneous pacing, TCP, how do you confirm mechanical capture? Option A. By looking at the ECG on the monitor. Option B. By checking a right carotid or femoral pulse. Option C. By the patient waking up. Option D. By seeing a pacer spike on the screen. The correct answer is option B. By checking a right carotid or femoral pulse. Electrical capture is seen on the monitor, spike followed by QRS, but mechanical capture must be confirmed by palpating a pulse that matches the pacer rate. Question 6. A patient is in P. The monitor shows a very narrow QRS with a rate of 40 bpm. What is the most likely cause? Option A, tension pneumothorax. Option B, hypovolemia. Option C, toxins. Option D, cardiac tamponade. The correct answer is option B, hypovolemia. Narrow complex P is most commonly associated with mechanical issues like hypovolemia or obstructive shock, tamponade/tension pneumothorax. Wide complex P is more likely metabolic, hyperkalemia/toxins. Question 7. What is the primary contraindication for using nitroglycerin in a patient with acute coronary syndrome? Option A, hypertension. Option B, heart rate of 100 bpm. Option C, recent use of phosphodiesterase inhibitors, example, sildenafil, within 24 to 48 hours. Option D, chest pain. The correct answer is option C, recent use of phosphodiesterase inhibitors, example, sildenafil, within 24 to 48 hours. Nitroglycerin can cause severe, life-threatening hypotension if used within 24 to 48 hours of phosphodiesterase inhibitors used for erectile dysfunction or pulmonary hypertension. Question 8. In the stroke algorithm, within how many hours of symptom onset must fibrinolytic therapy be initiated for most patients? Option A, 3 hours, up to 4.5 in select patients. Option B, 6 hours. Option C, 12 hours. Option D, 24 hours. The correct answer is option A, 3 hours, up to 4.5 in select patients. The standard window for alteplase, for TPA, is 3 hours from the last known well time, though this can be extended to 4.5 hours for specific patient populations. Question 9. A patient has a heart rate of 150 bpm and narrow QRS, vagal maneuvers and adenosine 6 mg/12 mg failed. What is the next step for a stable patient? Option A, immediate defibrillation. Option B, consult an expert and consider beta blockers or calcium channel blockers. Option C, atropine 1 mg. Option D, epinephrine 1 mg. The correct answer is option B. Consult an expert and consider beta blockers or calcium channel blockers. If adenosine fails to convert a stable narrow-complex tachycardia, the clinician should look for underlying causes, AFib/flutter, and consider longer-acting AV nodal blockers like diltiazem or metoprolol. Question 10. What is the gold standard for confirming correct endotracheal tube placement? Option A, bilateral breath sounds. Option B, condensation in the tube. Option C, continuous waveform capnography. Option D, chest X-ray. The correct answer is option C, continuous waveform capnography. While breath sounds are important, continuous waveform capnography is the most reliable method to confirm and monitor ETT placement. Question 11. A patient with a pulse is in unstable ventricular tachycardia. The monitor is in sync mode. You press the shock button but the device doesn't fire immediately. What should you do? Option A, let go of the button immediately. Option B, continue to hold the button down until the shock is delivered. Option C, turn the monitor off and on. Option D, switch to defibrillation mode. The correct answer is option B, continue to hold the button down until the shock is delivered. In synchronized cardioversion, the machine waits to deliver the shock on the R wave of the QRS complex. You must hold the button down until the device discharges. Question 12. Which heart block is characterized by a progressively lengthening PR interval until a QRS complex is dropped? Option A, first-degree AV block. Option B, second-degree AV block Mobitz I, Wenckebach. Option C, second-degree AV block Mobitz II. Option D, third-degree AV block. The correct answer is option B, second-degree AV block Mobitz I, Wenckebach. Mobitz I, Wenckebach, is the longer, drop pattern. It is usually benign but can progress. Question 13. A patient has a heart rate of 40 bpm and the ECG shows a constant PR interval followed by a sudden dropped QRS. What is the rhythm? Option A, Mobitz I. Option B, Mobitz II. Option C, third-degree AV block. Option D, sinus bradycardia. The correct answer is option B, Mobitz II. Mobitz II is characterized by a constant PR interval with intermittent non-conducted P waves. This is more dangerous than Mobitz I and often requires a pacer. Question 14. In third-degree, complete, AV block, what is the relationship between P waves and QRS complexes? Option A, they are always 1:1. Option B, the PR interval lengthens. Option C, there is no relationship, AV dissociation. Option D, P waves are absent. The correct answer is option C, there is no relationship, AV dissociation. In third-degree block, the atria and ventricles beat independently. There is no relationship between the P waves and the QRS complexes. Question 15. During ROSC, if the patient's BP is 82/50 mmHg, what is the first intervention? Option A, start an amiodarone infusion. Option B, for/IO fluid bolus, 1 to 2 L of normal saline or lactate ringers. Option C, immediate cooling to 32 degrees Celsius. Option D, give 1 mg epinephrine. The correct answer is option B, for/IO fluid bolus, 1 to 2 L of normal saline or lactate ringers. The first step in treating post-ROSC hypotension is a fluid bolus, 1 to 2 L. If fluid is ineffective, vasopressor infusions, norepinephrine, epinephrine, or dopamine, are started. Question 16. What is the recommended dose for a dopamine infusion in symptomatic bradycardia? Option A, 1 to 2 mg/kg/min. Option B, 5 to 20 mg/kg/min. Option C, 40 to 50 mg/kg/min. Option D, 100 mg/min. The correct answer is option B, 5 to 20 mg/kg/min. Dopamine at 5 to 20 mg/kg/min is a chronotropic dose used to increase heart rate when atropine is ineffective. Question 17. What is the common dosage for a norepinephrine infusion in post-cardiac arrest hypotension? Option A, 0.1 to 0.5 mg/kg/min. Option B 1 to 10 mg/hour. Option C 2 to 10 mg/min. Option D 50 mg/kg/min. The correct answer is option A, 0.1 to 0.5 mg/kg/min. Norepinephrine, 0.1 to 0.5 mg/kg/min, is a potent vasoconstrictor often preferred for post-ROSC hypotension. Question 18. A patient in VF has received 3 shocks. Epinephrine was given after the second shock. When should the next dose of epinephrine be given? Option A, immediately. Option B, after the third shock. Option C, 3 to 5 minutes after the first dose. Option D, never. The correct answer is option C, 3 to 5 minutes after the first dose. Epinephrine is administered every 3 to 5 minutes. The timing is independent of the shocks or rhythm checks. Question 19. You are performing CPR. The rhythm check shows a shockable rhythm. What should the compressor do while the defibrillator is charging? Option A, stop compressions and wait. Option B, continue chest compressions. Option C, give rescue breaths. Option D, check for a pulse. The correct answer is option B, continue chest compressions. To maximize the CCF, chest compression fraction, compression should continue while the defibrillator is charging. Clear the patient only when the device is ready to shock. Question 20. What is a common cause of pulseless electrical activity, P, after a successful shock for VF? Option A, the heart is stunned and needs CPR to help circulate blood. Option B, the shock was too low. Option C, the pacer is working. Option D, the patient has a stroke. The correct answer is option A, the heart is stunned and needs CPR to help circulate blood. After a shock, the heart may show a rhythm on the monitor but not have enough mechanical force to create a pulse. This is why we resume CPR immediately without a pulse check after a shock. Question 21. A patient presents with crushing chest pain and an ECG shows ST segment depression and leads V2, V4. What does this suggest? Option A, STEMI. Option B, ischemia or NSTEMI. Option C, normal finding. Option D, pericarditis. The correct answer is option B, ischemia or NSTEMI. ST segment depression or T-wave inversion suggests ischemia or a non-ST elevation myocardial infarction, NSTEMI. Question 22. What is the dose of 4-nitroglycerin for ACS if the patient is hypertensive? Option A, 1 mg bolus. Option B, 10 mg/min titrated to effect. Option C, 50 mg per minute. Option D, 100 mg/min. The correct answer is option B, 10 mg/min titrated to effect. For nitroglycerin is started at 10 mg/min and titrated based on pain relief and blood pressure stability. Question 23. In the stroke algorithm, how long should it take for a general neurologic assessment by the stroke team after arrival? Option A, 10 minutes. Option B, 25 minutes. Option C, 60 minutes. Option D, 120 minutes. The correct answer is option B, 25 minutes. The goal for the stroke team to perform a general neurologic assessment and NIH stroke scale, NIS, is within 25 minutes of patient arrival. Question 24. What is the most serious complication of fibrinolytic therapy in stroke patients? Option A, nausea. Option B, intracranial hemorrhage. Option C, itching. Option D, hypoglycemia. The correct answer is option B, intracranial hemorrhage. Fibrinolytics dissolve clots but carry a high risk of causing bleeding, specifically intracranial hemorrhage, itch, which can be fatal. Question 25. A patient is in ROSC. The ECG shows ST elevation, STEMI. What is the next priority? Option A, targeted temperature management. Option B, coronary angiography, cardiac catheterization. Option C, wait 24 hours. Option D, give more epinephrine. The correct answer is option B, coronary angiography, cardiac catheterization. Regardless of mental status, if a post-ROSC patient has signs of STEMI, they should be transported immediately to a facility capable of performing percutaneous coronary intervention, PCI. Question 26. What is the correct treatment for a patient in stable atrial flutter with a heart rate of 150 bpm? Option A, defibrillation. Option B, vagal maneuvers and consider rate control, beta blockers/calcium channel blockers. Option C, atropine. Option D, epinephrine. The correct answer is option B, vagal maneuvers, and consider rate control, beta blockers/calcium channel blockers. Stable atrial flutter is treated with rate-controlling medications or elective cardioversion. Vagal maneuvers may help identify the rhythm by slowing the AV conduction. Question 27. When should you consider terminating resuscitation efforts in the field? Option A, after 5 minutes. Option B, when the team is tired. Option C, when there is a persistent ACEs toll despite optimized ACLS for 20+ minutes and no reversible causes are found. Option D, after one shock. The correct answer is option C, when there is a persistent ACEs toll despite optimized ACLS for 20+ minutes and no reversible causes are found. The decision to stop CPR is clinical and based on many factors, but persistent ACEs toll after 20 minutes of high-quality ACLS is a strong indicator of futility. Question 28. What is the primary action of adenosine? Option A, increases heart rate. Option B, slows conduction through the AV node. Option C, increases blood pressure. Option D, relaxes bronchial smooth muscle. The correct answer is option B, slows conduction through the AV node. Adenosine acts by briefly blocking conduction through the AV node, which can break the re-entry circuit found in SVT. Question 29. A patient has a heart rate of 190 bpm, QRS is 0.14 seconds. The patient is stable. What is the rhythm category? Option A, narrow complex tachycardia. Option B, stable wide complex tachycardia. Option C, unstable tachycardia. Option D, sinus bradycardia. The correct answer is option B, stable wide complex tachycardia. A QRS 0.12 seconds is considered wide. Since the patient is stable, it is a stable wide complex tachycardia, likely VT or SVT with aberrancy. Question 30. Which medication is recommended for stable wide complex tachycardia to help differentiate SVT with aberrancy from VT? Option A, atropine. Option B, adenosine. Option C, epinephrine. Option D, norepinephrine. The correct answer is option B, adenosine. Adenosine may be used to help identify or convert a stable, regular, monomorphic wide complex tachycardia if it is actually SVT with aberrancy. Question 31. What is the purpose of the ROT phenomenon during cardioversion? Option A, to improve cardiac output. Option B, to prevent the delivery of a shock during the vulnerable period of repolarization which could cause VF. Option C, to speed up the heart. Option D, to check the battery. The correct answer is option B, to prevent the delivery of a shock during the vulnerable period of repolarization which could cause VF. Synchronized cardioversion delivers the shock on the R wave. If a shock falls on the T wave, R on T, it can induce ventricular fibrillation. Question 32. A patient is in cardiac arrest. The monitor shows ventricular fibrillation. CPR is in progress. The defibrillator is being charged. What should the team do? Option A, check for a pulse. Option B, wait for the beep. Option C, continue compressions until the defibrillator is charged and the person clearing the patient says, clear. Option D, stop compressions for 20 seconds. The correct answer is option C, continue compressions until the defibrillator is charged and the person clearing the patient says, clear. Minimizing the pre-shock pause is vital. Compressions should only stop once the device is fully charged and everyone is clear. Question 33. Which H's and T's causes most likely in a patient with a history of kidney failure and tall, peak T waves? Option A, hypovolemia. Option B, hyperkalemia. Option C, tension pneumothorax. Option D, toxins. The correct answer is option B, hyperkalemia. Hyperkalemia, high potassium, is common in renal failure and causes peak T waves, widening QRS, and eventually P/ACEs toll. Question 34. How should hyperkalemia be treated during ACLS? Option A, atropine. Option B, calcium chloride, sodium bicarbonate, and insulin/glucose. Option C, epinephrine only. Option D, defibrillation. The correct answer is option B, calcium chloride, sodium bicarbonate, and insulin/glucose. Treatment of hyperkalemia involves stabilizing the cardiac membrane, calcium, shifting potassium into cells, bicarb/insulin, and eventual removal, dialysis. Question 35. What is the first step when a patient with a pulse becomes suddenly hypotensive during a tachycardia? Option A. Give a fluid bolus. Option B. Check the sync button and perform synchronized cardioversion. Option C. Increase the dose of adenosine. Option D. Give atropine. The correct answer is option B. Check the sync button and perform synchronized cardioversion. If a patient becomes unstable, hypotensive, during tachycardia, you must perform immediate synchronized cardioversion. Question 36. A patient in ROSC is breathing 4 times a minute. What is the appropriate ventilation goal? Option A. No breaths needed. Option B. 10 to 12 breaths per minute, 1 every 5 to 6 seconds, to maintain a PEC O2 of 35 to 45 mmHg. Option C. 30 breaths per minute. Option D. Wait for the patient to wake up. The correct answer is option B. 10 to 12 breaths per minute, 1 every 5 to 6 seconds, to maintain a PEC O2 of 35 to 45 mmHg. Post-ROSC ventilation should be titrated to 10-12/min to maintain a normal CO2 level, 35 to 45 mmHg, and avoid hypocapnia, which causes cerebral vasoconstriction. Question 37. What is the effect of excessive ventilation, hyperventilation, during CPR? Option A. It improves oxygenation. Option B. It increases intrathoracic pressure, decreases venous return, and lowers cardiac output. Option C. It helps the AED analyze better. Option D. It prevents rib fractures. The correct answer is option B. It increases intrathoracic pressure, decreases venous return, and lowers cardiac output. Hyperventilation is harmful because it builds pressure in the chest, preventing blood from returning to the heart, which makes chest compressions much less effective. Question 38. A patient in SVT has a blood pressure of 70/40ths. What is the initial energy for synchronized cardioversion? Option A. 50 to 100 joules. Option B. 200 joules. Option C. 360 joules. Option D. 10 joules. The correct answer is option A. 50 to 100 joules. For stable but narrow complex tachycardias, SVT/A flutter, the initial energy is 50 to 100 joules. Atrial fibrillation usually requires higher, 120-200 J. Question 39. What does high-quality CPR mean regarding the compression-to-ventilation ratio for a team of 3? Option A. 30:2. Option B. 15:2. Option C. Continuous compressions. Option D. 10:1. The correct answer is option A. 30:2. In adult ACLS, the ratio remains 30:2 until an advanced airway is placed, regardless of the number of rescuers. Question 40. During a resuscitation, the team leader notices the compressor is not allowing full chest recoil. What is the correct action? Option A. Do nothing. Option B. Tell the compressor to stop. Option C. Provide constructive feedback. Ensure you allow the chest to fully recoil between compressions. Option D. Wait until the 2-minute mark. The correct answer is option C. Provide constructive feedback. Ensure you allow the chest to fully recoil between compressions. High-quality CPR is the foundation of ACLS. If a metric is not being met, the team leader must correct it immediately but professionally.